Cognitive theory and research on anxiety. One is cognitive therapy research on anxiety. Cognitive therapy is a theory-driven psychotherapy with a strong commitment to scientific empiricism. Its defining characteristics are not found in a set of unique intervention strategies, but rather in its cognitive conceptualization of psychopathology and the therapeutic change process. Thus, articulation of the cognitive model, as well as the derivation of testable hypotheses and their empirical evaluation, are critical to determining its construct validity. Similar to the organization of earlier primary treatment manuals of cognitive therapy, this book begins with a focus on the theoretical and empirical foundation of cognitive therapy for anxiety. Anxiety, a common but multifaceted condition. Love looks forward, hate looks back. Anxiety has eyes all over its head. Anxiety is ubiquitous to the human condition. From the beginning of recorded history, philosophers, religious leaders, scholars, and more recently physicians, as well as social and medical scientists, have attempted to unravel the mysteries of anxiety and to develop interventions that would effectively deal with this pervasive and troubling condition of humanity. Today, as never before, calamitous events brought about by natural disasters or callous acts of crime, violence, or terrorism have created a social climate of fear and anxiety in many countries around the world. Natural disasters like earthquakes, hurricanes, tsunamis, and the like have a significant negative impact on the mental health of affected populations in both developing and developed countries, with symptoms of anxiety and post-traumatic stress showing substantial increases in the weeks immediately following the disaster. Elevated levels of anxiety and other post-traumatic symptoms spike in the first few weeks after acts of terrorism, war, or other large-scale acts of community violence. In 5 to 8 weeks after the September 11, 2001 terrorist attacks on the World Trade Center towers in New York City, symptoms of post-traumatic stress disorder doubled. An internet-based survey found that 17% of individuals outside New York City reported PTSD symptoms 2 months after 9/11. The National Tragedy Study, a telephone survey of 2,126 Americans, found that 5 months after the 9/11 terrorist attacks month, 30% of Americans reported difficulty sleeping, 27% felt nervous or tense, and 17% indicated they worried a great deal about future terrorist attacks. The Gallup Youth Survey of American teenagers, conducted 2.5 years after 9/11, found that 39% of teens were either very or somewhat worried that they or someone in their families will become a victim of terrorism. Although large-scale threats have their greatest impact on the psychological morbidity of individuals directly affected by the disaster in the weeks immediately following the traumatic event, their wider effects are evident months and years later in the heightened concerns and worries of a significant proportion of the general population. Fear, anxiety, and worry, however, are not the exclusive domain of disaster and other life-threatening experiences. In the majority of cases, anxiety develops within the context of the fluctuating pressures, demands, and stresses of daily living. In fact, anxiety disorders represent the single largest mental health problem in the United States, with more than 19 million American adults having an anxiety disorder in any given year. Approximately 12 to 19% of primary care patients meet diagnostic criteria for an anxiety disorder. Moreover, antidepressants and mood stabilizers are the third most prescribed pharmacotherapy class, having 2003 global sales of $19 billion American dollars. Thus, millions of people worldwide month a daily struggle against clinical anxiety and its symptoms. These disorders cause a significant economic, social, and health care burden for all countries, especially in developing countries that face frequent social and political upheavals and high rates of natural disaster. This chapter provides an overview of the diagnosis, clinical features, and theoretical perspectives on the anxiety disorders. We begin by examining definitional issues and the distinction between fear and anxiety. The diagnosis of anxiety disorders is then considered with particular attention to the problem of comorbidity, especially with depression and substance abuse disorders. A brief review of the epidemiology, cause, and consequence of anxiety is presented, and contemporary biological and behavioral explanations for anxiety are considered. The chapter concludes with arguments for the validity of a cognitive perspective for understanding the anxiety disorders and their treatment.